and they can learn and gain some learning credit here as well. Hope you're okay with that.
Absolutely. Thank you.
Thank you. Justin, back to you, please.
Oh, certainly. Well, thank you very much for welcoming Susan. Susan Hedlund is a pleasure to have on the call and to join us today. Is a professor in the School of Division of Hematology and Medical Oncology in the School of Medicine, and has been an oncology social worker for the past 30 years plus, I think. Is that right, Susan? Um, and has worked, in the provision of, I'm reading some of her bios here, working around psychosocial support for those with cancer and their loved ones. And she's presented to BDMS before at the leadership level, talking about her work around palliative care and how she coordinates wellness offerings around yoga, mindfulness, stress reduction, exercise, massage, retreats to kind of bring together a holistic approach to palliative care to support our work at the Knight Cancer Institute at OHSU. And maybe, Susan, you can fill in a bit of the gaps that I've missed there, but we're just delighted to have you back. And thank you for presenting today.
Thank you, Justin. It's a pleasure to be here. Been looking forward to it.
And before you start, if I can just also introduce Dr. Eston Yang, who's with us from Southern Oregon. He's a newcomer to this group. He's going to be looking at working in Thailand and supporting a lot of our student and faculty opportunities in surgery for Thai partners in Bangkok and northern Thailand, and wants to sort of see how you might be useful to this collaboration as a surgeon trained at OHSU and working in this field for the last many years. So Eston, thank you for joining us, and he'll be on the calls going forward if he has time.
Oh, he will be staying in Thailand.
Oh, periodically. He just got back from a trip meeting with leadership and is keen to learn where his skill set might fit in with BDMS as well as with CROT and MFU.
Oh, okay, okay. Thank you. Welcome, welcome.
So much. Super. So, Britta, nice to see you. Thank you for joining. See you on the call. Lovely to have you. And I think I've seen Kim as well on the call. So we have a good team here from OHSU. So that's our introductions. I'll pass it back to you, Wanapa, and thank you for having us. And whenever, Susan, you're ready.
Okay. Thank you. I am going to attempt to share my screen, and I'm going to ask y'all if you're able to see it. Are you able to see my screen?
We sure can. It's not on the full screen yet, but it's coming through nicely.
Oh, good. Thank you so much. And I'm going to try not to touch anything because periodically my computer just silences me. I think it's tired to talk. So there we go.
Looks perfect. Thank you, Susan.
Thank you. So Dr. Zikidis, who I believe many of you are familiar with, asked if I would kind of launch your GI series and talk specifically about cancer survivorship and how we support patients and families through the continuum of care. I'd like to talk a little bit about the field of survivorship because it's still evolving and we are learning so much about what it is that patients and families want and need as they not only navigate the cancer experience, but also through the rest of their lives having had cancer. So that's what I'm going to talk about today. I spoke before Thanksgiving with a different group that Justin works with about cancer survivorship, just I think around Thanksgiving, prior to Thanksgiving. Was that about right? I think, Justin. And one of the things that we talked about is the definition of a cancer survivor. Now, I will say not everyone loves the word survivor, but it is the term that has been agreed upon in the literature that describes anyone who's been diagnosed with cancer from the time of diagnosis through the rest of his or her life. Historically, we used to talk about cancer survivorship in terms of people who had been treated for cancer and they were done with treatment and they were disease-free 5 years after treatment. But we've really moved away from that because so many diseases don't fit that 5-year continuum. We know that people can be disease-free from breast cancer for decades and still have the cancer come back. And so we've moved away from that. And the National Coalition of Cancer Survivors were the ones that really coined this definition, which is the one that most of us use. And here it was this graphic at the bottom describes that obviously, ideally, we want to prevent cancer. Then we detect it. There's a diagnosis. A person goes through treatment. And then we enter what's called the survivorship continuum. And I'll talk more about that. But in the United States, the reason that this has become such an important field of study is that we see that back in 1975 in the United States, we had 3.6 million cancer survivors. But in 2040, it's estimated that we will have 26.1 million cancer survivors. That's really wonderful news. It means that many people are successfully being treated for cancer and living a very long time afterwards, disease-free. Obviously, we've made more progress in some diseases than others, but this is a really good trend. But it also really showed us the need to develop separate services, or at least a view of survivorship as the next phase along the continuum of care. If my research serves me well, I hope I got this right, that in Thailand, about 232 people are diagnosed with cancer per 100,000, and the most frequently diagnosed are breast, colon, cervix, lung, and liver. And we know that colorectal cancer is prominent globally, especially in more higher income regions. However, there are barriers to care, both in the United States and in Thailand. And again, I am no expert on cancer in Thailand, and so it is with great humility that I join you this evening. But the research I was able to do, it came up with some themes that were very similar to what we experience in the United States, which is there's a shortage of medical oncologists in general. There is not equal access to care, particularly in rural regions. Some of the newest treatments may not be affordable to many patients. And we know that there's later diagnoses and greater mortality for those who have less access to early screening or education regarding the value of screening. And there's also a number of barriers to genetic testing that continue to exist in both countries. So cancer survivorship in the United States, which I'm more familiar with, has been an evolution. It was really first acknowledged back in the 80s by someone by the name of Fitzmullen, who wrote about seasons of survival and talked about how it isn't over just because your active treatment is done. You're still dealing, sometimes for years, with the sequelae that follows active treatment for cancer. And this was also something acknowledged by the early founding of the National Coalition of Cancer Survivors in the 80s. And specifically, it acknowledged that many patients found it difficult to transition to post-treatment life. I remember early in my career, we used to have little celebrations when people would finish chemotherapy. We still ring the bell and when people are done with radiation treatment. But many patients told us that they were really frightened. They were frightened because they didn't necessarily know how to feel safe if they weren't in active treatment. They had less surveillance once they were out of active treatment, and often felt like their life had changed, but they were still getting used to what that would look like. Along early in those years, the National Comprehensive Cancer Network also issued guidelines for survivors. And the cancer survivorship has become now kind of a movement which acknowledges both the short and the long-term side effects of treatment, comorbidity risks, and the late effects of having been treated with cancer. And it's also become a quality of life issue. Some of the key reports over the last 20 years, back in 1999, there was the Ensuring Quality Cancer, Crossing the Quality Chasm, Unequal Treatment, Confronting Racial Disparities. And the really pivotal one that had to do with cancer survivorship, which was produced by the Academy's Press, which used to be the Institute of Medicine, was called From Cancer Patient to Cancer Survivor, Lost in Transition. And I'll talk a little bit more about that in a moment. But then we had Cancer Care for the Whole Patient, Health of Lesbian, Gay, Bisexual, and Transgender People, Delivering High Quality Health Care. And there have been a number of others since that time as well that have been important. But this was the real pivotal work by the Institute of Medicine that was published in 2005, so almost 20 years ago. And this led the Commission on Cancer in the United States to develop a standard related to cancer survivorship in 2015. The Commission on Cancer is under the broad umbrella of the American College of Surgeons. And the Commission on Cancer is tasked with accrediting all of our cancer centers in the United States, and they uphold our cancer centers to certain standards of care relative to the way that we take care of our patients. I happen to sit on the Commission on Cancer representing my profession of oncology social work, and I was there when they wrote the survivorship standards. But we found that they were hard to meet, and I'll talk a little bit more about that in just a moment. But this Institute of Medicine book really suggested these domains as being really important as we take care of cancer patients. They thought that we should establish cancer survivorship as a very distinct phase along the continuum of care. They also very much suggested providing survivorship care plans to each person when they finished treatment. They suggested that we use evidence-based clinical guidelines to support patients that are out of active treatment, that we develop quality survivorship care measures, that we demonstrate and test survivorship care programs, that we include survivorship in comprehensive cancer control program plans, provide educational opportunities to healthcare providers, and I would add patients, and ensure access to affordable health insurance in the United States and address employment issues and expand funding on survivorship research. Again, this was recommended to us almost 20 years ago, but we're still trying to figure out how to best do that. We know that survivorship care plans was strongly recommended not only by this particular text, but also by the Commission on Cancer in ASCO. And they made it part of its mandate for cancer program accreditation, but progress was very slow. And I'll talk about why that was in a moment. But survivorship care plans were essentially twofold. One was a treatment summary, in other words, looking back at what kinds of treatment the patient had experienced, all the tests, diagnostics, the tumor types and characteristics, the dates and details of their therapies, all adjuvant therapy, psychosocial, nutritional, and other support services, contact information for facilities and key clinicians, and the identification of a primary contact. This got cut off, but that was for primary care. And then the second part of the survivorship care plan was to really look forward, or a wellness plan, if you will. And here it was suggested that we give patients suggestions for ongoing health maintenance, cancer screening plans, evaluation for late and long-term effects, signs of recurrence or secondary malignancies, ongoing psychosocial support, insurance, employment, and financial referrals, healthy behaviors, and genetic counseling. And this is ideally what should be in survivorship care plans. What we found when the Commission on Cancer made this a mandatory part of survivorship, the survivorship standard, was people were having a really hard time meeting the standard as it was written at that time, which was that 100% of our patients would receive these care plans. It was cumbersome for a number of reasons. One was the length of the document. Here in the United States, we have multiple electronic medical records that don't interface, and they didn't auto-populate the survivorship care plan, which meant it was very time-consuming for someone to hand enter all that information about a patient's care and surveillance guidelines, and there was no reimbursement for creating that document. There was lack of role clarity on who should complete it, and a lack of data on whether or not they actually worked. In other words, did it translate into patients really taking a more active role in surveillance post-treatment? And it was the lack of data, that led a lot of providers to be very skeptical about the benefits of survivorship care plans. And unfortunately, there was a hope early on that eventually our cancer patients would return to primary care, and the primary care providers would be responsible for the screening that would continue. But we found that that didn't gain a lot of traction either. So we revised the standard in 2019, And what we did was we gave much more latitude for United States cancer programs to set their own survivorship program goals that made the most sense for them in their own settings and resources. The standard as it was originally written, we lost sight of what the intention was, which was to view survivorship as a separate component in the continuum of care. And instead, it got very focused on the care plans. We know that not all cancer centers are created equal in the sense that our tiny rural cancer centers may not have the resources to provide some of these services that a large academic or urban-based medical center might. And so the change in the standard allowed cancer programs to have more latitude to set the program goals that made sense for them. When I work with our patients, generally speaking, I try to evaluate what cancer patient survivors need, and they generally fall into 4 different categories. And I'll go through each one of these individually. But one is the physical well-being, everything from functional status to pain. Social well-being, in other words, how has a person's life been affected in terms of their relationships with others? Psychological well-being, including things like anxiety and depression or cognitive change, and spiritual well-being, how one makes sense of it and finds meaning in the illness or is able to cope going forward. And I want to go through each of these individually because they're really important components of taking care of the patient after treatment and during treatment as well. So physical well-being really refers to overall functional status. We want to look at things like fatigue, sleep, pain, ongoing neuropathies, dental issues, fertility issues. I would add sexual issues. And generally speaking, it can be helped by patients returning to a more active lifestyle. But we know that for some patients, they have short and long lasting fatigue, again, neuropathies that they may be dealing with. They may have a lot of sleep disturbances and a challenge returning to functional status. After a number of months, if people haven't been able to return to an active lifestyle, it may really become important to refer to specialists, whether it's a physical therapist, to an exercise program, or to a pain management clinic or similar specialties. But this is one of the domains that I think remains very important even after active treatment is completed to help our patients stay as healthy as they can. Psychological well-being is something that my team is very steeped in each day. We know that having cancer is distressing to people. But often during active treatment, people don't have the psychological bandwidth to deal with all the emotions. And what I find as a social worker, it's often after active treatment that patients come to us and say, wow, I'm trying to make sense of what I've been through. How have I changed? How have I not changed? And it may be accompanied by feelings of grief or sadness or sometimes anger about what they've been through. And that it's not uncommon to have these emotions surface after treatment, sometimes during treatment, but very common after treatment. And we know that 30% of cancer survivors experience significant anxiety, and a significant number of our patients experience depression, 25%. And this percentage goes up the closer to end of life that people are. So we know that we want to address this as well through education and support, referrals to stress reduction specialists, mental health providers, and at times medication. We want to make sure that we are attending to the overall quality of life and addressing cognitive changes, which is not uncommon for some of our patients. Certainly fear of reoccurrence, which is very, very common for most cancer survivors, and addressing a sense of control. Many of our patients tell us, and this is, I think, very Western, but they feel so out of control as a result of having had cancer and want to regain some sense of efficacy in their lives as they move forward. Social well-being is an incredibly important piece of this. We've come to believe that cancer is not just a disease of a person, but it has an impact on family and friends. Some families become overly protective of the person who's had cancer. Some friends may withdraw, others come more forward. But many times patients tell me that their families want them to return to how things were before cancer happened. And my patients will tell me, I don't even know who that person is now because so much has changed as a result of having cancer. Priorities may change, boundaries may change, what a person wants to do with their life may really change. We also know that work can be very disruptive and the financial impact of cancer can be great. Some people tell us they feel very isolated in the cancer experience, and others experience embarrassment about either physical appearances that have changed or some of the intimacy issues that they are struggling with. So social well-being is another area that is really important to address. And then finally, spiritual and existential issues, everything from how do I make sense of this illness? Is my faith strengthened or is it challenged as a result? Are my faith practices helpful to me? Some people really struggle with the notion of hope and uncertainty. You know, there isn't necessarily a guarantee that the cancer won't ever return. And then others find an incredible amount of inner strength. They may transcend the distress that they have experienced and really discover their resilience as they adapt to all of this. But all of this takes time. This is not something that happens overnight. And one of the really important things to remember is that, again, cancer is many, many, many different kinds of diseases. And therefore, survivorship and what a person needs in survivorship may be very different from one person to another as well. In the United States, the people that have the most experience in survivorship care are pediatrics. It's when we started to really cure some of our pediatric cancers that we realized that as these children got older, they needed to have ongoing follow-up and surveillance. And there's been a lot of research that's been done in pediatrics around survivorship. And we have many examples of wonderful survivorship programs in pediatrics. We have one here at the hospital where I work. And then we've struggled in the adult world to figure out the right model for delivering survivorship care. Some settings set up disease-specific models. So, for example, the University of Nebraska has a program where they have a general survivorship clinic and then a special survivorship clinic for the patients who have undergone bone marrow transplants, because their ongoing long-term effects are often more complex than some of their other patients. There are some programs that use a consultative clinic model so that a person may be referred if they've developed certain kinds of late effects that need to be attended to. Some programs have developed multidisciplinary clinic models, and then others have what we call an integrated care model. And then some programs have wanted to transition back to primary care, although I haven't seen very many examples of that being successful. As I mentioned, we are still evolving models of care. But one of the most important components of any model that we use is interdisciplinary communication, so that we are working together to address the holistic needs of our patients. Some of the challenges, as I mentioned, is that cancer patients represent a very diverse group of people, and each disease has its own specific needs in treatment and in survivorship. No one model works for everyone. And the ongoing struggle that I hear from my colleagues nationally are resources, lack of staff that are trained to do this, and lack of funding to support the programs, because many of the services in survivorship in the United States model are not reimbursed. And so that remains an ongoing challenge. I'm hoping as time goes on and we evolve some different payment models in the United States that perhaps that will change. Last year, the National Coalition of Cancer Survivors, they always do an annual report, and they surveyed about 2,300 patients. And their report last year suggested that in the United States, their survey was that 70% had their work productivity affected by cancer, 43% experienced financial hardship, and 6 in 10 patients utilized what we call integrative medicine practices to really focus on well-being. And in that large category of integrative medicine, it includes everything from prayer, exercise, diet, mindfulness-based stress reduction, yoga support groups, and those are some of the services that exist in the program that I direct here at OHSU. They concluded that patients needed to feel empowered, they continue to need to advocate for themselves, and to really convene collectively to share their challenges. I did a study, this is a difficult chart to read, so I apologize. I did a study here at our own center last year in which we have a program where patients can opt in to answer surveys, and we asked patients what they really wanted after treatment. And what we found in both the pediatric and the adult world was that 65% really wanted more help in terms of nutrition and mental health services after treatment. So really telling us that they wanted more help in figuring out a healthy, nutritious diet. They wanted more support psychologically. But then, as you can see, there are other things that mattered to them, such as sleep management, spiritual care, exercise, caregiver support, etc. And I think the reason I share this with you is that I always think it's important to ask our patients what they feel like they need. Many survivorship programs have been provider-driven and lacking in the patient's input, including our own. And so we are trying to change that currently where I work. So I want to spend a little bit of time talking about kind of the ideal vision of a comprehensive survivorship program. And truth be told, we've not created it yet here where I work, but we're working on it as we speak. But ideally, a comprehensive survivorship program should provide expertise in cancer survivorship care through clinical practice, research, and professional and public education. And as I mentioned, it really should begin with diagnosis, continue during and beyond treatment, recovery, reentry into one's world throughout the duration of that person's life, if that's possible. It also includes recommended surveillance that may occur inside or outside of the healthcare system. And the access should be multiple points of entry throughout one's cancer trajectory, because a cancer patient's needs will change over time. So if we can make it easy for people to access services wherever they are on the continuum, that's ideal. Now, again, this is an ideal vision, and it's hard to get there sometimes, but it's a place to aim for. Some of the key elements of a successful survivorship program include an interdisciplinary approach with a direct and interactive relationship with patients, families, and providers. And I think we need the key players at the table, excuse me, patients, a whole host of survivorship providers, including physicians, nurse practitioners, physician assistants, social workers, primary care providers, rehab and exercise, integrative medicine, nutrition, mental health services, fertility, financial navigators, geneticists, sexual health specialists, and palliative liaisons. And that's a lot of people. And trying to get them to work collaboratively can be daunting. But I think if we can start small and have it scalable and continue to grow as we learn about this, and depending on the setting we're in, it's possible. This is a patient-centered survivorship care framework that was based on a study out of George Washington University that brought together all 1,200 cancer survivors to talk about what would patient-centered survivorship care look like. And I like this diagram because it talks about the alliance between patients and providers and health systems, and also the information that the patients need. And so you see that in this wheel, you have everything from care coordination to prevention and wellness services, care transitions, information, and support. But I like this visual because, again, at the center are patients, and this is what they tell us would be ideal for them. So again, cancer survivorship begins at a diagnosis and optimally goes well before, well during and after treatment. There is a term in the literature called cancer prehabilitation, and that is something we are seeing being implemented more frequently in our cancer centers in the United States. That's a process on the continuum of care that occurs between the time of diagnosis and also the beginning of acute treatment, which includes both physical and psychological assessments to determine baseline functional levels. So, for example, in my setting, we automatically bring in physical therapists prior to people having bone marrow transplants. We bring nutritionists in prior to doing surgery for head and neck cancers, with the intention of trying to reduce some of the treatment-related morbidity and optimize care. So it's a much more proactive approach in bringing in our rehabilitation and nutritional specialists. We can make referrals to resources as needed, care is communicated and coordinated. We would recommend that the physician or other provider review the correct surveillance and follow-up guidelines. And again, there's a need to continue to have access to comprehensive services and updated recommendations. Now, again, this is the ideal state. And in my setting, we are working very hard to build a model that will promote at least some of these key elements. But we want to also create guidelines by type of survivorship care. One of the groups that I think is really superb in this is the NCCN, that's the National Coalition of Cancer Networks, and they have survivorship guidelines. They have GI cancer guidelines in terms of survivorship care, and a lot of great recommendations. And you have access to that online. That can be really, really helpful. Education of both oncology and primary care providers, research tools to develop our programs, and the establishment of informatic pathways to bring patients into systems and look at different survivorship types within oncology specialties. Some of the value drivers are to manage the risk. What we want is the improvement on recommended patient follow-up to decrease recurrences and have earlier identification of treatment sequelae. We want patient engagement by equipping patients and families with information and tangible products, and ideally increase both patient retention and satisfaction. These are lofty goals, but I think achievable. So if you're looking to create a program, I think it's important to start small and create, set program goals and also make it scalable if possible. If you start small and work out some of the logistical problems, that can really inform your next steps. As I mentioned, involving patients early on with focus groups, advisory councils, patient navigators, using what are called patient-reported outcomes, which are usually much more accurate reporting than what we might surmise, developing survivorship services and research opportunities, and then collect performance and impact data, and then evaluate. Again, if you start small, I think it's possible to do all of these things. This is borrowed from the George Washington University, but this is a self-assessment scale that can help you maybe begin to develop your program. You'll have access to all of these slides, but I like this particular assessment tool where you can rate yourself on a scale of 4 to excellent, and across these domains. The cancer survivors receive emotional and social support. Cancer survivors receive information and resources about expectations post-treatment. They are empowered and engaged. Clinicians are supportive and prepared. There's meaningful communication between clinicians and cancer survivors. There's care coordination and transitions across providers, and that cancer survivors have the full spectrum of care, and that cancer survivors have what we call a medical home. So this might be a tool that if you're thinking about starting a survivorship clinic or program, that this may be a place to start as you really interview your stakeholders and think about what pieces you have. So for example, in my own institution, We have some, but not all of these components in place, but by far and away, we are not well coordinated. And that is something that we need to really break down the silos and start to be much more fully coordinated than we currently are in my institution. I mentioned patient-reported outcomes. I'm not sure if you've been utilizing these, but they're any report of the status of a patient's health condition, health behavior, or experience with healthcare teams that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. And the reason that this is important is that research has shown us that there's a lot of discrepancy between what physician-reported symptoms are and what patient-reported symptoms are. And the patient experiences the symptoms usually are somewhat greater than those reported by physicians. And so, again, there's nothing like getting patients in the room to course correct if we are going down a path that may not necessarily match what their expectations or experiences might be. One of the things that I've been talking with a colleague of mine about, who is much more of a researcher than I am, is how do we begin to really enhance the research that is done on cancer survivorship? It's a way of really trying to enhance health and well-being of survivors and set the gold standard of what we should be doing so that we can prevent and mitigate acute and late occurring physical, psychological, social, and economic effects of cancer and its treatment, improve care delivery, promote healthy behaviors, develop and sustain research infrastructure, and improve our methodologies. You know, we have some, but not a lot of research yet. Again, it's a relatively newer field over the last, 10 to 20 years. And because we're still trying to figure out what's the best way to deliver these services, not surprisingly, our research isn't as robust as I hope it will be in another 20 years in terms of how we are supporting our patients and survivors. But we want to look at the acute physiological or psychosocial toxicities. We want to look at long-term effects of cancer, late effects. We want to look at healthcare delivery, the financial impact in cancer care economics, and health promotion and health behaviors. All of these things I think are important in the research domain to try to evaluate what is most helpful. The researcher I was just mentioning, and she and I have been tapped to really take our survivorship services to the next level, is wanting to do a study on loneliness. And her background and research expertise is in cancer-related exercise post-treatment. And one of the things she is finding is that her patients in the exercise program that report a lot of social isolation and loneliness also are experiencing much higher levels of depression than their counterparts who aren't lonely and socially isolated. So just really important things for us to be thinking about as we think about the cancer care continuum. So other assumptions for a strong program are to maintain a database of survivors, evaluate how we're doing, and use our evaluations to do implementation science and quality improvement. And then again, trying to access services across the continuum. I live in a very rural state, and so one of the things we are realizing is that we need to do much better outreach to our more isolated communities in our state. And one of the ways that we are doing that is through the use of community health workers and the development of patient navigators that can help the people who live in their communities who are living with cancer or on the other side of active treatment. And as I mentioned, using the patient voice early and often in program development. This is a list of kind of resources for you around practice guidelines. As I mentioned, the National Comprehensive Cancer Network has all kinds of resources by topic that can be very, very helpful. ASCO, the American Society of Clinical Oncology, also has a whole lot of resources that can be helpful. The American Cancer Society as well, that has site-specific as well as holistic guidelines in survivorship care. A lot of really good materials, both for patients as well as for providers and of care for our patients. Some other resources, the George Washington University, which I have referenced a lot, They have free downloadable trainings, educational materials that anyone can access. And it's one of the best sites that I've seen in terms of cancer survivor information. The National Institute of Health has also got a lot of different evidence-based practice and programs and other kinds of things. And I have a whole host of references here that I won't bore you with, but in a moment I'll stop sharing and ask for questions. But I want to end with this because it's something I'm really proud of. During the pandemic, we have 3 writing groups in our cancer program. And during the pandemic, our groups were more well attended than ever because we offered them virtually. And I think it was a way to reduce the isolation that the pandemic imposed. And some of the writers came to me and asked if we could publish their anthology. And this is a book that I just love. It's an anthology of cancer patients' stories called We Become a New Story. And it really reflects so many of the themes I've just been talking about, how one's life is transformed as a result of the cancer experience. And the bird on the cover of this book, which I really love, was painted by one of the participants using pieces of fabric that another participant who has since died used to make these beautiful quilts. And I think, again, the message that we become a new story is one to remember that cancer changes one's life. And often for some people, their identity, their priorities, their experience in the world. And I think it's an important piece of us as providers to keep in mind always. So I'm going to stop sharing and just invite you to ask any questions that you might have. If I confused you in any way, please let me know that as well. Or to share any of your experiences in taking care of cancer survivors and things that have been successful.
Thank you very much, Susan. Dr. Thirawut, I think you are the one who kindly request for this one. Any question for her?
Thank you very much, Susan. You give us very consolidated data about the survivorship in US and inspire us a lot from your lecture. I just wonder about, there is some overlap thing about the survivorship program and the palliative care program.
Thank you for that question. Yes, and actually the medical director of our palliative care program and I discuss this regularly because many times, as you all know, as providers, our patients, even if they're treated with curative intent, may continue to carry the late effects or side effects from treatment. And he and I dream of having a clinic that is what we would like to call a supportive care clinic, because we know that many of our patients don't entirely understand the term palliative or fear that it's pre-hospice. And we would really love to bring the concept of palliative care much further upstream to offer it to all of our patients, but most especially to our patients who are carrying a lot of high symptom burden, either as a result of their cancer or its treatment. And so we work very closely together, and I think there's so much opportunity moving forward to co-create services between palliative and survivorship care.
Thank you very much. So I'm just thinking that we can start our program by to persuade our palliative care to start with. Is it a good idea?
I think so. I think so. We have automatic palliative care referrals for certain patients, our patients with pancreatic cancers, our patients with brain tumors. Some of our advanced ovarian cancer patients, we have automatic referrals to palliative care, particularly to deal with the symptom burden, even if they are being treated with hopefully remission in sight. But I think it's a very good idea to combine. Yeah.
Thank you very much.
Any other palliative care team question? I have seen you guys attend as well. Palliative team.
Okay, this is Dr. Darin. I'm a palliative care consultant at Vattanosot Hospital. Thanks for your wonderful lecture. Could you please give us the idea, like the model that your clinic is running the survivorship program right now, and I'm wondering about the transition process from finishing treating cancer patient into a survivorship program. What would be the idea or suggestion to start with the transition? Thank you.
You're welcome. Thank you for the question. So we are still working out our challenges. So I would not in any way say we've been successful in creating an ideal survivorship program yet. We're still working on it. What we have been told by our patients is that they have a very hard time leaving their treating team in oncology. They don't want to go to a separate survivorship clinic. They want to stay with the people who knew them through their cancer and their treatment. And so that's been challenging for us to move our patients away from the oncologists into the survivorship care clinics because they don't necessarily want to go. They feel much safer being cared for by the oncologists who knew them. So one of the things that I've talked to people around the United States about how they've dealt with that. And some, like for example, Memorial Sloan Kettering Cancer Hospital in New York, they begin introducing the idea of a survivorship clinic at the very beginning of care for their patients. And what they will say is, after you finish treatment, we will be transitioning you to our survivorship program. And so they try to introduce that idea up front so that they will, not be surprised by it. The other thing that can be helpful is if you staff a survivorship clinic with people who absolutely know oncology. I think that's very important, but have visibility when people are going through active treatment. So it won't be a stranger that they're sent to, but rather this is part of our team. And we are giving what we like to call in the United States a warm handoff to our teammate because they will take very good care of you and we will stay in touch with them. We didn't do it right the first time. We're modifying our approach as we speak.
All right. Yeah, I think that's a very great suggestion. So what you are saying is if we could introduce ourselves or have early consultation to supportive care center, that would be a
Yes.
great way to get to know patient from the beginning, right?
Absolutely. When
Okay.
I was a baby social worker a long time ago, I worked with an oncologist who had every single one of his patients meet me as a social worker. And he did that because he wanted them to know that I was here if they needed me, but he did it also to take away the stigma that some patients feel if they're referred to a social worker. Oh gosh, did I do something wrong? And so I got sent to the social worker. And it was really helpful because then I was seen as part of the team. I wasn't seen as an exception. It was just part of the care. And so I think if you did a similar thing by introducing your program and your clinic and your team early on, then it's not a surprise for patients and they don't feel abandoned in any way.
Thank you for your answer.
Thank you for your question. Are there other questions or examples of things that have worked for you?
I like to hear out the idea from other side as well. Ajahn Vinita, how about your thought for survivorship or palliative at the Smithivet?
I'm sorry, you broke up at the end there. I'm not sure I got the question correctly.
Oh, no, it's not a question. I asked Dr. Vinita to ask you if she wished to have some comment for this.
Oh, I see. Thank you. So
Ajahn Vinita. Vinita, you have any question for them?
Okay, do you hear me?
Yes, I can now.
Okay, I'm Dr. Minita Naka from Summit Vet Hospital. So, some of the patients with,
We lost your voice.
okay, do you hear me? Sorry, my signal was quite bad right now. Do you hear me?
Just barely.
Just faintly? Sorry. Or, hello?
I hear a bit ไม่เป็นไรเดี๋ยวไมโครเป็นไมโครโฟนให้อาจารย์ได้อาจารย์พูดมาเลย
Okay. Sorry, Tajan. So my microphone just broke out this morning, so try to use this. Sorry. Okay. Do you hear me now?
Better.
Better, right? I'm sorry, my bad. So here in Summit Hospital, we do have some patients with cancer, colorectal cancer, pancreatic cancer. But what we're facing now is that everybody works as isolated, not a team, like GI doctors, oncologists, and we try to establish a team that working together as a team. But for what's still lacking is that we don't have a nurse who like cooperating all of the cancer patients together. And also this is private hospital, so we don't have any social workers to try to like keeping things together in terms of holistic care of patients. So I was sharing our experience here, but I think in government hospital they do have social workers who are taking care of patients, but most of them are taking care of patients that have low income status. Most of them taking care of that one. So that's I want to sharing our experience here.
Yeah, thank you, Benita. I think that historically, in many systems, social workers were used primarily to deal with the financial burden that many of our patients experience. We've been really fortunate in my setting that our clinical role is really to provide the mental health services to our patients, which I feel very grateful for. And it's difficult if you don't have the infrastructure. And I would just add, Benita, that we too, even though we have the infrastructure of nurses and social workers and palliative care and that kind of thing, we still become quite siloed. We don't work together in a comprehensive, integrated way that I would like to see us do, because then that leaves patients to navigate each of these different services sort of on their own. And so the vision that the program proposal that I'm trying to create right now with my colleague is one that would truly create an infrastructure to bring us all together, or at least to try to some people to coordinate it, because I think that's where patients get lost in the process too.
Thank you so much for your answers. So we'll try to do that, and if there's any suggestion, I would like to give ask for your opinion about this. But thank you.
Absolutely. Please reach out anytime. We're all learning as we go with all of this. And I think that we probably have more similar problems than different ones. And so love to collaborate.
Thank you.
Thank you. We have 5 minutes. Any other side would like to ask or comment on Susan's talk today?
Susan, can I ask you a question?
Sure, of course.
So we have nurse navigators or cancer navigators who are nurses who help us kind of coordinate both testing and appointments for our patients who see multiple, like liver surgeons, colorectal surgeons, oncologists.
Yeah.
How do they get incorporated in the ideal survivorship program? Because these patients know the nurses, because they say, oh, I'm going to help you arrange for your CEA or your Signatera test, and then your colonoscopy will be sent this day, and then your MRI will be right afterwards.
You bet.
So they know these nurses, they trust these nurses, but then when they finish surveillance, I mean, this is a full-time job they can't do the survivorship too. So how do they get incorporated in your ideal program?
The way you described it, Dr. Lou, is exactly how they operate in our system. And that's part of the disconnect. You know, when treatment's over, you know, it is a full-time job. They're very, very busy and they're really good at what they do, but then it's over. So one of the things that I've been tasked with creating for us, and believe me, I haven't done it yet, so, but I want to be totally honest about that. Our cancer center director has said we need to build out an infrastructure that includes lay navigators, patient navigators, and community health workers to help extend that reach. And I don't mean that as volunteer work, I mean as paid positions. I've been in touch with a number of people nationally as I try to figure this out about how do we train lay navigators to, or patient navigators, and then pay them to help be available to patients as they hit that next transition. Because our nurses are wonderful, and again, they have full-time jobs, as you said. And so once we do that, my hope would be that, again, there's a relationship coming forward that we begin to prepare patients that at the end of treatment, you will be able to be followed by our patient navigators who are part of our program, and they will help us. And then also the mutuality of, if the lay navigator becomes concerned about something that's going on for the patient, that they can directly reach out to the nurse navigator to get re-involved.
And what do you think about social media nowadays? Because I have patients who reach out to Facebook and they have Facebook groups on low anterior syndrome for rectal cancer. And it's a very busy group where they're talking about, I can't poop, I'm having incontinence, I have clustering, and my doctors don't like to talk about this. So what do you do? And they all answer tap water enemas. But I mean, aside from that, I mean, people are reaching out to other patients for advice, and maybe that helps them heal by saying, well, it sucked for me, but if you do this, it could be better for you.
You know, I think it's a mixed bag. I think the benefit of social media is people feel less isolated. They can sometimes connect with people who've really been there and may have some practical good suggestions about how to deal with, you know, being constipated or having these other things that are going on for them. I think it's useful to have somebody that has some training to kind of facilitate those discussions, because I think what happens sometimes is that misinformation can become really abundant on social media sites. And so I know, for example, I facilitate a couple of groups in the community that specifically asked me to step in so that I can try to help navigate and monitor the conversations and try to steer people back to what might be a better idea. Not that I'm a physician, I don't mean to suggest that at all, but I think some social media groups are better than others. And as we know, the internet also is a mixed bag of information, some more accurate than others. So I always encourage patients to go to trusted sources. And I also always encourage people to, when in doubt, go back to your provider. They're the ones who know this disease. They're the ones who know if this is a symptom to be really worried about.
Thank you. We have few minutes. Can I have a last question from any other side, please? 3, 4, 5, 6. Anyone?
So Susan, maybe the last question. So concerning the same idea at the social media, how about your idea about a volunteer in this survivorship program? Is good or not?
Volunteers?
Yeah.
I think if they're well trained, absolutely. I think I do a little bit of training for different community nonprofit groups on patient volunteers, like kind of a peer mentoring, if you will. And I think volunteers can be a really good idea as long as you have good training and good supervision. Because you really, again, for the same reasons about social media, you want to make sure that the information out there is sound, and that they're getting good support. And so I think if we train volunteers and help them understand the scope and the limit of the role, and then have good supervision, it can be a great value add because it can extend your service and support without a huge hit to your budget. It's a great question.
Your volunteer, do you need them to sign any paper with the OHSU before working?
Yeah, they have to go through a whole series of trainings on confidentiality and understanding that they're not there to give a lot of advice, and a whole training program for that. But once they're through that, then they're good to go, and they're a really valuable part of the program.
Thank you. I think we reached the time. We learned a lot today. And
thank you for having me.
Thank you very much. Happy Chinese New Year to everyone.
Yes, happy Chinese New Year. I'm sorry I failed to say that up front. And again, please feel free to reach out if I can be a resource to you at any time.
Thank you. Bye-bye.
Thank you, Susan. Thanks, everyone. Thanks for joining us. And thanks, everybody. Sawasdee krap.